Record is in progress, and I will turn it over to Dr. Khanna, who's with our Desert Cardiology Center, and he'll give his background and the speaking about what our talk is about tonight. But I always have the pleasure of working with the doctor and learn so many new things. So sit back and enjoy.
Thank you so much, Brett. Good evening and welcome. It's a pleasure to share with you what we've been doing at Eisenhower with our valve program over the last 5 or 6 years. I'm going to speak about the transcatheter aortic valve replacement procedure today. It is a specific valve replacement procedure done for aortic stenosis. We started this program at Eisenhower about 6 years ago. We are now ranked amongst the top 10% of programs in the country. We actually just recently got recognized for that and have been designated as a benchmark program, which only 10% of programs in the country are. What that means is that we will actually be bringing, the company that manufactures the device will be bringing physicians from all over the country to watch us do procedures and show people how they can be done efficiently and effectively. So with that said, I'm just going to go ahead and move through what is aortic stenosis and what is it that we do when we are doing a valve replacement without opening the chest, which is what we're going to talk about today. So here on the screen, what you can see is the heart. On the left-hand side, the heart has 4 different valves in it: the mitral valve, the aortic valve, the tricuspid, and there's a pulmonic valve as well. What we're going to talk about today is the aortic valve. This is the valve through which all the blood comes out of the heart. And a healthy valve looks like this when it's closed, and it looks like this when it's open. So it has 3 flappers in it that open and close with every heartbeat. What happens in a certain number of patients is they develop hardening and thickening of this valve. And this is often the result of inflammation, sometimes a viral infection, sometimes just shear forces from blood flowing across the valve. And what happens is the valve begins to get calcified. So it becomes thickened, it becomes scarred, and this happens initially. It is mild. As it progresses, it becomes moderate. And then when it gets to be severe, most patients develop symptoms. So this picture here on the right-hand side is actually a real picture of an aortic valve that is diseased. And you can see where the flappers would normally open. You can see these big nodules of calcium and scarring that cause it to not open properly and create a problem. So what happens to these patients? Normally, when you look at an aortic valve, it's about, from above, it's about the size of a quarter or maybe a little bit smaller. Most of these patients, by the time they begin to develop symptoms, the valve is about the size of the top of a ballpoint. So the heart is actually trying to push blood through a very narrowed orifice, and it can't push enough blood through. And the blood begins to back up in the lungs get boggy with fluid, and patients get short of breath, particularly when they are exerting. The other thing that happens is you get lack of blood supply to the heart muscle itself, and that gives patients chest pain that is similar to having a blocked artery in the heart, what we call angina. The other thing that happens oftentimes is that these patients will get shortness of breath, and they can get lightheaded and dizzy because there's just not enough blood getting to the head. Sometimes people will actually pass out from this problem as well, and they can lose consciousness. And then this can also trigger abnormal heart rhythms that can be potentially fatal. So any of these symptoms tell us that the valve is now a problem and it needs to be fixed. The other thing that's important to know is that when these symptoms occur, it is an indication to intervene, because if you don't, there is a 50% chance that that patient will not be alive 2 years later. So the moment a patient has symptoms and they have aortic stenosis, they basically risk stratify themselves as someone that is at high risk for having a bad outcome if we don't do something about it. How do we find out that the patient has aortic stenosis? More often than not, this is something that's picked up by a physician. When they listen to the patient's chest, they hear a audible systolic murmur. So they can actually hear with their stethoscope a whooshing sound. And the simplest way I can explain this is if you think about a water coming out of a hose, and you were to stick your thumb on the top of the hose, the water comes out faster. That's basically what's happening. As the valve gets narrower and narrower, the velocity or the speed of blood flow coming out of that valve gets higher and higher, and it makes a whooshing sound that can be heard with the stethoscope very easily. This also decreases the volume of the pulse. So if you feel the pulse of the patient in the carotid or their radial artery on their wrist, it is not a strong pulse. It is a weak pulse. And that's, again, because there's limited blood flow coming out of the heart. The next step is usually a echocardiogram. And the echocardiogram is an ultrasound image. Here on the top panels, I'll pause this so that I can explain it. The aortic valve is this valve over here. And when I play it, you can see the flappers are opening and closing as the heart beats. In a patient who has aortic stenosis, that's this valve over here, you see how thickened it has become. And when I play this, you will see that it's really not opening properly. Those leaflets are kind of stuck together. This is a view at 90 degrees where you're looking down on the valve itself. And so when you look at it from above, it looks like a little Mercedes sign with the flappers opening and closing. Trying to get this to play. So you can see the leaflets are opening and closing. It looks like a little Mercedes sign opening and closing. There's a cartoon here on the side that shows what we're looking at. This is the aortic valve. And then when you look at it here, you can see that those leaflets are thickened. They're not opening properly. And there's a very small, much smaller opening here than on the left-hand side, which is a normal valve. So that's what we look at when we do an echo test, and we're able to tell that the patient has aortic stenosis. We're actually able to measure how bad that valve is with the echocardiogram. And this is a completely non-invasive test. It's an ultrasound test. So we take a microphone, we put a little jelly on it, and we rub it on the chest, and we can get these images. It takes about a half hour to do a complete examination and determine how bad the problem is. Well, what happens once you've made this diagnosis of aortic stenosis? If you have a patient, and I spoke to this a little earlier, who has symptoms, and those are the symptoms that we talked about, if they're having chest pain, if they're short of breath, if they're fatigued and tired, if they've had dizziness or a passing out spell, if you do nothing, only 50% of these people are alive 2 years later. And at 5 years, 4 out of 5 have died. So this actually has a prognosis that is worse than most cancers. And this is something that really needs to be emphasized because we now have such a good way of treating this. How do we treat this? Well, there's a couple of different ways to treat this problem. The old and traditional way, which is still a very good way and still used in many patients, is what we call a SAVR, or a surgical aortic valve replacement. This is done with an open chest procedure, and here's a diagram that shows you how it's done. We actually go in, we split the sternum and open the chest, go in. The heart is actually in cardioplegia, so we actually stop the heart. We put the patient on what we call a heart-lung bypass machine. So the machine is doing the work with the heart and the lungs while we're working. The heart is opened like it's shown over here. We actually cut the valve out and we size with different cylinders what size valve is going to go in there. And then we take that size valve, it's a 25, it's a 27, and we sew that valve in with 35, 40 sutures around the valve to hold it in place. And once we've done that, we suture the heart back together. We jump start it with paddles, and then we close the chest incision and bring the bone together with stainless steel wires. Now, that's a big operation. I don't do those operations. Those operations are done by our cardiac surgeons, Dr. Wilson and Dr. Logsdon, and we'll show you they're part of our team when we work on patients who have this problem. The traditional open chest procedure that's down the middle is a big incision. In some patients, this can be done with a limited incision. You can do a right anterior thoracotomy, which is a smaller incision to the right side of the sternum, the big bone in the chest. And sometimes you can do a mini incision where you're splitting only part of the bone, not the entire bone. But all of these procedures require a heart-lung machine and general anesthesia. And most of these operations are about an hour and a half to 2 hours, if not 3, and require an ICU stay for a day or 2, and then a hospital stay for 5 to 7 days. Most patients are able to go home after a week and recover within a matter of 4 weeks. They're fully recovered from the surgery. So if you look at the graph of patients who have aortic stenosis and patients who have had surgical valve replacement versus patients who don't have surgical valve replacement, what you see is that the patients who have had a SAVR, that's this blue line, actually have a much better outcome. At 5 years, like we spoke about, 80% of the patients who were not treated have passed away. So the surgical valve replacement clearly impacts mortality and longevity in these patients. And once you've done a surgical valve replacement, you basically have given the patient the same lifespan as a patient who does not have aortic stenosis. How common is this problem? Well, there's 250,000 patients who basically qualify for a surgical valve replacement every year in the United States. Surprisingly, only about a third of these patients are actually getting their valves replaced. Up to 2/3 of these patients will actually not have surgery, and that happens for a variety of reasons. Oftentimes, these patients are older. Doing a big operation with an open chest procedure is a difficult recovery for someone that's 85 plus. Oftentimes, these patients are frail and are not capable of having such a large surgical procedure. Some of these patients have had prior heart surgery, so they have scar tissue within that makes it much more difficult. A lot of these patients have issues with their kidneys, with their lungs, so they're suboptimal candidates to do open procedures on. So what we are now able to do, particularly for these patients that are very high risk for surgical procedures, is we can do this valve replacement without opening the chest. And this is what we call a TAVR, or a transcatheter aortic valve replacement. This is a technology. When we started out, initially this was only approved for patients who were at prohibitive risk, meaning the surgery was so high risk that it was prohibitive to even the surgeons wanting to operate on these patients. So the initial patients that actually got a TAVR were the patients that the surgeons were not happy or not willing to operate on. And the FDA gave approval to do TAVRs on those patients in 2011 because there was really no other good option for those patients. And in fact, there was a clinical trial that showed that those patients had better outcomes with a TAVR than they did with a surgical valve replacement. The next group was the patients who were at high risk, meaning their risk of having a bad outcome was about 7.5% or higher. and with surgical valve replacement. So these patients were then randomized, and they took about 1,000 patients or 1,500 patients, and half of them got a surgical valve and half of them got a transcatheter valve. And what we found was we had better outcomes in even the high-risk patients with a valve replacement that was done without opening the chest. That same procedure was then repeated with patients who were at intermediate risk and low risk in 2016 and 2019. These were randomized clinical trials done. And what we found was that in all risk groups, patients actually had better outcomes with a TAVR than a surgical valve replacement. Part of this was because it was less invasive. Part of it was to do with the fact that we are now delivering a valve to a beating heart rather than putting the heart in standstill when we operate. So the routine way to do a valve replacement is through the artery in the groin. We go in from here and we go all the way up to the heart to replace the valve. But there are patients in whom we cannot do that. They have blocked arteries in their legs, or they have issues that they've had procedures or surgical procedures where there's too much scar tissue down here and we can't get in. In those patients, we can actually approach the valve replacement with our transcatheter valve, and we will sometimes go in from an artery that's underneath the collarbone. Our default access site now at Eisenhower has become the carotid artery, which is the artery in the neck that goes to the brain. So we're actually able to go in from here, go directly into the heart, replace the valve, and come out. And this takes a small incision right here in the neck. Now that sounds kind of scary because you're going in the artery that supplies blood to the brain, but there are two arteries, and we make sure before we work that both are nice and open, because one flow in one artery is sufficient to keep the brain perfused and protected. There are also the options of going directly into the chest and into the aorta, and sometimes directly into the heart. And we did that initially when we had started out, but most programs have gotten away from a direct heart approach because that tends to be a little bit more invasive as well. What does this valve look like? Here's a picture of the valve. It has a stainless steel cage that you can see here. And this beige part up here are the three flappers. These three flappers are made from the lining of a cow's heart. They basically open and close like a normal valve does in the heart. Down here below the, in the lower part of the steel cage is what we call a skirt. And this is actually a material that helps seal any leaks around the valve. This is what the valve looks like when it's implanted in the heart itself. Here, this is the aorta, and down here is the heart. And this is what the valve would look like under X-ray when we have put it in. And that's about the size of the valve. So this is a hand with the valve in it, as you can see. Obviously, the valve can't go into the body when it's that large. So what we do is we actually take this valve and we crimp it on a balloon. So instead of being that big, it becomes about the size of the pinky finger on that hand in diameter. And this is how we prep it. This is what our equipment looks like. This is the tube that goes into the groin. We put this in into the artery, and that goes up to the aorta. This is what the equipment looks like that delivers the valve, and this is the balloon at the end of it. So this is a enlarged picture of the tip of this catheter, and this is what the valve looks like when it's crimped down and the balloon is not inflated. And what we do is we advance this all the way into the diseased valve. We position it carefully and we inflate the balloon, and when we do that, the valve opens like this. And it becomes embedded in the old valve, and the old valve gets pushed into the wall of the heart and becomes scar tissue, and the new valve becomes functional immediately, and then we're able to withdraw this delivery equipment and the valve stays in place. So I'm going to show you an animation here. This is the valve coming in on our catheter. This white rectangle that you see is what the valve looks like when it's crimped down. So we actually bring it up, and then what we do is the balloon is actually ahead of the valve just to decrease the profile of the delivery system. And once we get it inside the body, what we do is we bring the balloon back inside the valve, and then we advance the entire system up to the heart. So you'll watch this. See, we bring it here, and now we're bringing the balloon backwards. And we lock that into place. And now we advance this all the way up to the heart, and this is advanced over a wire, the stiff wire that allows us to move this forward. Here's the bad valve, the bad aortic valve, and you can see that the heart is beating. We bring this in under X-ray guidance. We align the valve so that it is sitting within the diseased valve. We can actually adjust the angulation on the catheter. We can move it sideways. We can move it up and down. We bring it up a little bit. We position it exactly where we want it to be. Now, once we have it where we want it, we flutter the heart and we expand the valve. And this valve locks into place because the old valve has a lot of calcium in it. And then we're able to withdraw the equipment and remove it. And the valve has become functional now. So this comes out of the groin. And we basically are able to deliver a couple of stitches, seal the access point, and take all our equipment out. And now the valve is functional in the heart, with the flappers opening and closing. That's what it looks like from side to side. That's what it looks like from above. And the heart's pumping, and it's happy because now there's not an obstruction of the blood flow coming out of the heart. And this is actually what it looks like live. Previous was an animation. So you can actually see here. I'll bring that back a little bit. So here's the valve sitting here. This is the native valve. The diseased valve sits over here. This is our crimped valve on the balloon. We've positioned it exactly where we want to. And you'll see that the heart is beating when we're positioning it, and then you'll see the heart fluttering. And the way we do that is we put a temporary pacemaker in the heart, and we actually speed the heartbeat up to about 200 beats a minute. So if you look at my hands here on the screen, you'll, are my hands visible, right, or no? Yeah. So normally the heart's beating like this. And if you're trying to deliver on a valve, a valve in a heart that's beating like this, you can't really position it. So what we need to do is we need to have the heart stand still. And so when we speed the heart rate up to 200 beats a minute, what the heart does is it's doing this, it's quivering, and it's really not moving. And I can do that for 30 to 60 seconds without any adverse effect to the patients. But in those 30 or 60 seconds, I have to position the valve exactly where I want it, and I have to expand it. So we sort of have this little dance that we do. We put a temporary pacemaker in, and we say, pacemaker on. We take an injection of dye. We see exactly where the valve is sitting. If we're happy with it, we say balloon up, balloon down, and pacemaker off. And then the valve is delivered. So the actual delivery of the valve takes all of 30 seconds. It takes about a half hour for me to get my equipment in and a half hour to get my equipment out. So the entire procedure is about an hour to an hour and a half. Bring this back, sorry. I'll play this for you so you can see what it looks like in real time. Here's our valve sitting over here, and you'll see the heart's, now we're fluttering the heart. You see an injection of dye, and then the valve expands. And our valve is good. It's embedded where we need it to be. And we take our equipment, delivery equipment, back. And that's literally how long it takes to deliver the valve. That little picture that you're seeing over there, that's real time. And at the same time, we're doing an echo test so that we can actually look at the valve, and you can see the valve's flappers are opening and closing nicely here. And we look at it in different views, and you can see it in this view here as well. I get this to play. So you see the flappers here opening and closing as well. And the way we do this is when we get into the artery in the groin, and this is a picture of us getting into the artery. It's a tiny little incision. You can see how big this incision is. That's my hand there, and that's my finger compared to the incision. We actually deliver sutures into the wall of the artery that are coming from the wall of the artery out to the skin. And after we've delivered those sutures, we put our tube in that is going to allow us to deliver the valve. And when we take this tube out after delivery of the valve, we basically pull on these sutures that are sitting here, and we cinch them down, and it basically seals the artery, and that's what my incision looks like after I finish the procedure. So the other thing that's of interest is that when we're doing this procedure, when we started out, we were doing patients with anesthesia. Patients are now no longer under general anesthesia. They are asleep with a little bit of medication. We kind of put them in a twilight zone. We can actually wake them up and talk to them during the procedure. This is kind of similar to what you might have if you were having a colonoscopy or a scope to look in your stomach. You're actually awake and breathing on your own. We don't put you on a ventilator. That makes the recovery much faster. It keeps you from having any complications of general anesthesia. And about 90 to 95% of our patients are being done with local anesthetic and a little bit of twilight sedation. So when you look at the graphic representation of these patients who underwent a surgical valve replacement compared to a transcatheter aortic valve replacement, you see that out at 2 years, and this was what we base all our data on, and this is what the FDA gave us approval for, is that there were actually better outcomes in the patients who got a transcatheter valve than a surgical valve replacement in terms of all-cause mortality. So there were more people alive at 1 year and at 2 years with a transcatheter valve rather than a surgical valve. And even with mortality and disabling stroke, the data favors TAVR versus surgical valve replacement. So less stroke, although the confidence intervals and p-values on this were not as significant as the mortality. But a overall 20% reduction in risk of death or stroke if you used a transcatheter valve versus a surgical valve. This was what was called the Partner 2 trial, and this was a seminal trial based on which the FDA gave approval for valves, transcatheter valves to be done. This is the low risk trial, and this was the group of patients who were felt to be at low risk for having a surgical valve replacement. And even in these patients, if you looked at the risk of death, stroke, or being rehospitalized, the data favors of a transcatheter valve versus surgery. And this is 450 patients who underwent a TAVR, 374 patients who underwent surgery, followed out to 12 months. Again, this is the partner 3 low risk trial looking at the combined endpoint of death or disabling stroke. Again, more favorable for TAVR versus SAVR. So what does our valve patient look like? Oftentimes, the low-risk patient is someone that's relatively younger, in their 60s and their 70s. They have some symptoms of shortness of breath. They tend not to be frail. Their risk of having a bad outcome with surgery is only, 1 or 2%. They don't have other issues. Their lungs are not bad. Their kidneys are not bad. They don't have, severe diabetes that's uncontrolled. The intermediate patient is oftentimes a little bit older, oftentimes in their 80s. They have some more issues with frailty. They may have arthritic changes. They may have difficult mobility. And then you have the high-risk patient, the 88-year-old who has significant other problems. They may be on oxygen. They may have lung problems. They may have diabetes. They may have a previous pacemaker. That patient is really not a good candidate to try and do an open procedure on, and definitely will have a transcatheter valve replacement done. So how do we make this decision? We have what we call the heart team, and our heart team has physicians. We have interventional cardiologists that are people like me. So there's actually 3 of us. There are cardiac surgeons, and there's 2 cardiac surgeons, and I'll introduce you to the whole team here shortly. We have valve clinic coordinators, and these are the wonderful nurses who run our valve program, and they are what make this magic happen, really. And then we have our anesthesiologists that help us look after these patients during the procedure and after the procedure. We have referring cardiologists who make our diagnosis and refer the patient for these procedures. And then we do CAT scans and imaging, ultrasounds on the carotids, on the heart, the aorta, and that's our radiologists who sort of give us the roadmap. So it's really a multi-specialty team that has to be brought together, and it's a significant undertaking to make this happen. We started down this path 6 years ago, and we have, I can tell you now with a lot of pride that we have probably one of the best teams in the country now to do this procedure. In fact, we have now taken this technology even further. We are doing what we call valve-in-valve procedures. So this is actually a little picture of a patient who has a valve that had been implanted before. So he'd already had a surgical valve replacement, and you see this wire cage over here. This is the surgical valve. This was put in about 14 years ago. The patient is now in their mid to late 80s. That valve is failing. Previously, the only option for this patient was to actually go in, do another operation, and replace this valve again and open their chest again. Now what we're able to do is actually bring our TAVR valve in from the groin artery, and we position it within the old surgical valve. And as you can see, we do exactly the same thing. We expand this valve within the surgical valve, and the new valve is functional immediately. So this patient gets a new valve without ever having to open their chest and is able to go home the next day. So we've done this not only for aortic valves that have been replaced, but for surgical valves that are in the mitral position. And we're actually one of the few institutions in the country that has done this for a tricuspid valve as well. And here's an animation of what that looks like when we're doing it in the mitral position. So this is the old surgical valve, and we basically expand our TAVR valve within the old valve and it becomes functional immediately, and then we're able to withdraw our equipment. And this is the actual image of what it looks like under X-ray. So as you can imagine, it's much more challenging and difficult to be doing a second operation for a surgeon on a patient who's already had their chest open once, because you're having to go through all the old scar tissue to get to the heart and replace the valve. So the preference always is to do it with catheters, and that's the way to go. Much less risk of complications, much less risk of having a bad outcome. This again is just an animation to show you what the aortic valve looks like when it's diseased. And how we go in from the groin. We actually thread a wire up all the way up to the heart. We take that wire across the bad diseased valve while the heart's still beating. And we're doing all of this under X-ray guidance. Oftentimes we'll bring a balloon up, make room on the bad valve. We'll crack the valve with just a balloon procedure first. And then we'll take the balloon out. And then we'll come in with our sheath. That's our tube that helps us deliver the valve. Here comes our TAVR valve, crimped on top of a balloon. We advance it into the diseased valve, and we've made room for that by cracking the valve open with a balloon before. We position it, and then we flutter the heart, and we expand it. The valve becomes functional right away. And we get our equipment out. Wire comes out. And the patient has a new functioning valve. So here's our heart valve team. There are 3 interventional cardiologists, myself, Dr. Pangaluri, who joined us about 2 years ago, and he trained at Scripps Clinic in San Diego. He's been a wonderful addition to our team. Dr. Frutkin, who's been at Eisenhower with us for about 10 years now. He and I were the ones that started the program, and it's actually been wonderful. We've got his name wrong on the slide. I'm sorry. It's Andrew Frutkin. But little typo there. But those are the interventional cardiologists. Dr. Wilson is our cardiac surgeon. He's been at Eisenhower for almost 30 years as well. He helped us start the program. Terrific cardiac surgeon. And just recently, Dr. Logsdon has joined us. He's been here almost, I think, 8 months now. He's been a great addition. And so when we see a patient who has an aortic valve problem, what happens is they actually come in, they have their tests done. The valve clinic coordinators, who are these 3 angels who run our lives and our valve program, make everything happen. It's Crystal Hastings, Don Pittman, and Sarah Walenchek. They're just terrific. They're the primary contact for the patients. They take charge of these patients. They get them through their investigations. They set up all their tests, and they are the direct line communication to patients who are getting a TAVR valve or a surgical valve. And once all that data is accumulated, we have a meeting on Wednesday. We have 5 physicians in the meeting, usually the physicians on the heart team. We have the valve clinic coordinators, and we sit and we look at all the tests together. We discuss the angiogram, the echo test, the CAT scans, and we make a decision whether it's best to proceed either with a surgical valve replacement for the patient or whether we should use a transcatheter valve for that patient and how best to approach it. Do we go in from the groin? Do we do a carotid? And that's a great discussion because you get the benefit of 5 experienced, skilled operators from different specialties who are able to give input. And we believe that's integral and important to achieving the wonderful outcomes that we've been able to do in our program. And the valve clinic coordinators make all of this possible and streamline the entire program, make us look good every day. So kudos to them for all the work they do. That's the talk. Happy to take any questions.